Does cognitive behavioral therapy, or CBT, really work, or is it a scam? This slideshow will review the conceptual framework of CBT and the methods of CBT efficacy studies. The basic concept of CBT, that negative cognitions are the cause of major depressive disorder, or MDD, is the only instance in all of medicine and psychiatry where a symptom of an illness is also construed to be the cause. Negative cognitions such as I don't deserve anything, am I a nobody, nobody likes me, etc., can be construed to be a secondary psychological reaction to depressed mood. Giving persons hope and support may decrease negative cognitions and depression scores, but does not change the underlying disorder. Whether primary or secondary, they may be easily assuaged by unblinded psychotherapeutic intervention. In addition, placebo shows significant improvement in depressive symptoms in clinical trials. It is working on these easily assuaged negative cognitions that improve with the hope and expectation of the possibility of getting an effective drug. Also, because response in a clinical trial of depression is defined as a 50% improvement on a rating scale, a responder may still have 50% of their symptoms remaining, and thus a person may still be ill but deemed a responder. Negative cognitions usually improve when depression is treated with medications, and this suggests that the negative cognitions were secondary to the depression, not the cause. On the methodologic problems in CBT studies, a major criticism has been that clinical studies of CBT efficacy, or any psychotherapy, are not double-blind. In other words, neither subjects nor therapists in psychotherapy studies are blind to the type of treatment. They may be single-blinded. In other words, the rater may not know the treatment the patient received, but neither the patients nor the therapists are blind to the type of therapy given. So 2 out of 3 of the persons involved in the trial and all of the persons involved in the treatment are unblinded. The patient is an active participant in correcting negative distorted thoughts in CBT and thus quite aware of the treatment group they are in. The therapist is naturally a believer in the therapy approach and may transmit this hope to the patient in some way, and large uncontrolled bias is the result in these studies. A meta-analysis examined CBT when placebo control and blindedness were factored in. Published trials of CBT in schizophrenia, major depressive disorder, and bipolar disorder that use controls for nonspecific effects of intervention were analyzed. This study concluded that CBT is no better than nonspecific control interventions in the treatment of schizophrenia. Treatment effects are small in the treatment studies of major depressive disorder, and CBT is not an effective treatment strategy for relapse prevention in bipolar disorder. For major depressive disorder, the authors note that the pooled effect size was very low at 0.28 for the Hamilton Depression Scale and 0.27 for the Beck Depression Inventory. These studies, not being blind, make these small differences, likely due to unblinded bias. Another methodologic problem is born from the fact that not all persons with depressed mood have an illness of depression, especially the milder forms, which are more likely a mixed bag of persons with personality issues and/or psychosocial problems who more easily improve with some coaching. For these milder patients, the element of hope and expectation on the part of the patients to get better in these non-blinded trials will bias the results in favor of CBT. In addition, the informed consent procedure to be able to enter a psychotherapy trial biases the subjects who enter to those who are favorably inclined to the psychotherapy. Another study noted that the specificity of CBT and IPT, or interpersonal therapy, treatments for depression have yet to be demonstrated and details likely reasons, and that this efficacy of these therapies is no different to other kinds of appropriate psychotherapies. Taken together, a number of psychiatrists have concluded that CBT may help some parameters of psychosocial function, but that CBT is not a treatment of an illness. CBT is not more specific than other standard treatments. CBT should not be used as a standalone treatment in moderate or more severe depression. CBT should not be considered an evidence-based treatment intervention. Thank you for listening to this video.